Thanks, Anju, and the Department of Medicine for this opportunity. Before I go on, just a few things. I know that most of you PGs are in some sort of a COVID haze, either pre-duty, post-duty. And so actually a lot of the stuff in this seminar, I will give you the resources or I'll tell you the one or two review articles that you can use later for reference and especially for exams also. Uh, Also that we know that you've not been able to have a posting in specialities. The practical knowledge definitely will be missed, but having said that, we'll try and make this talk as practical as possible so that when you actually approach a case, you'll have some idea of how to approach and how to go about it. So feel free to stop in the middle at the end of ITP, and then at the end again, I'll stop and take questions, or you can put it in the chat box. So we'll start off with TTP. So to start off with ITP, the slides of this are mainly from the lecture I took for the PG seminar in HIMAT about 6 months back. So if some of you attended that, it might be repetition for you. So ITP now stands for immune thrombocytopenia, and it's an acquired thrombocytopenia defined as a platelet count of less than 1 lakh caused by immune destruction of platelets. So old terms of immune thrombocytopenic purpura, that's out. The ITP now just stands for immune thrombocytopenia. So basically, pathologically, it is characterized by peripheral thrombocytopenia with the presence of adequate megakaryocytes in the bone marrow. So some definitions, these definitions are updated in 2009. ASH stands for the American Society of Hematology Guidelines. So if you come to an acute or a newly diagnosed ITP, is an ITP within 3 months of diagnosis. Anything between 3 to 12 months is a persistent ITP, and anything more than 12 months is a chronic ITP. Early response is, if you look at this slide, you see that 30,000 seems to be the magic figure, and we'll come to that. So durable response is platelet more than 30,000, or at least a doubling. Early response is within 1 week to hit 30,000 platelets, and an initial is within 1 month if you hit 30,000 platelets. Okay. Important note that refractory ITP means thrombocytopenia that persists after splenectomy. That's the definition of a refractory. Steroid dependent ITP is when you need a minimum level of prednisolone or a steroid to keep the platelets above 30,000, or if you need frequent pulses of high dose steroids. Coming to the evaluation, very, very important is, like in anything in medicine, is history. So an ITP, we'll come to the epidemiology, and when it comes about, it's usually seen as an acute presentation, maybe preceded by a viral illness, maybe an upper respiratory tract infection or a GI infection, followed by which there is a precipitous drop of platelets to usually a severe level initially at presentation, and mucocutaneous bleeding. So platelet type bleeding is usually mucocutaneous, so petechiae, purpura, wet purpura. So those are the important things to look for. Very important in ITP is to look for what it's not there. So we try, when a child comes with thrombocytopenia, we're trying to rule out more sinister causes in the history and physical examination. So you ask for history of other cell lines that are down. Now, if there had been severe bleeding, like in an adolescent who has menorrhagia, then there may be anemia. But otherwise, usually the other two cell lines are unaffected. So you won't have symptoms of fatigue, may not have symptoms of fever, or at least a high fever or an ongoing something severe like a bacterial infection. Physical examination to rule out lymphadenopathy, hepatosplenomegaly, other nodes, bony pains. Again, basically rule out things like acute leukemia. So history and physical examination, family history is very important. Is it any other bleeding disorder which is presenting in childhood that we are missing out? A mild bleeding disorder, or like at a time of menarche, whether it's a platelet type bleeding disorder due to von Willebrand or other things like Lanzmann's thrombasthenia or Bernard-Solier, those things have to be kept in mind. So blood tests that are usually asked for are a complete blood count, reticulocyte count, peripheral blood smear to look for abnormal cells, to look for parasites. Quantitative immunoglobulin measurements are useful because if there is presentation in adolescence or by the third decade, one of the causes of ITP is CVID, especially if there's other multi-system organ involvement. Coming to bone marrow examination, we'll have a separate slide on that. Blood group BCT, basically if we want to think of anti-D as therapy, we'll need to know that. Now the second column is very important. Those are tests which are frequently asked for. Do we do ANA? Do you do dsDNA? Do you do viral tests for parvovirus and CMV? Not in all cases. Now, if there is history suggestive of an ongoing autoimmune process where the ITP may be a secondary ITP, In those cases, yes, ANA, dsDNA, complements, urine routine, and 24 urine protein. Otherwise, specifically not. If there's history suggestive of recurrent pregnancy loss or thrombotic events, then to look for antiphospholipid antibody syndrome. So avoidance of that second level of expensive investigations, if there's no positive history and if it's a first episode, we can get by with just the basic evaluation. And the last column of tests are almost never done and only in research settings for specific indications for papers. Now, coming to the bone marrow and the diagnosis of ITP, again, this audience is mainly an adult population, adult audience, I understand. But ITP, if you see, there is a bimodal distribution. So very often we see it in a young age group and an older age group. So the presentation, the workup is also slightly different. So in a child, if a child comes up with just thrombocytopenia and there's no other abnormalities on physical examination, other cell lines are normal, and if there's no abnormal cells and no splenomegaly, then the definite role of a bone marrow is not there, and especially if you treat them with IVIG or anti-D and not on steroids. So in a child, the bone marrow is deferred for a longer time. In an adult, we must very carefully look for malignancies, myelodysplastic syndrome, which may not be that easy, but if there's any other cytopenia, even a mild leukopenia with a macrocytosis, all those are hints towards maybe an MDS or a bone marrow failure syndrome, which is presenting. So in these conditions, you have to do a bone marrow. Second is if you've already given IVIG or anti-D, or again, steroids given outside and come, very often our patients are referred here after treatment elsewhere and there's no response, which is why they're coming to us. In those situations, yes, definitely a bone marrow. Prior to giving expensive treatment like thrombopoietic agents or a very invasive procedure with long-term consequences like splenectomy, definitely a bone marrow must be done. Prior to starting steroid, the American Society of Hematology actually advises prior to starting steroids in all adults, a bone marrow should be done even if it's upfront. So having said that, what are the secondary cause of ITP? We all know the autoimmune conditions. Other things that we often forget are HIV can present first time with thrombocytopenia. So a patient who comes with thrombocytopenia, a blood-borne viral screen is very important. CVID, if there's history of recurrent GI upset, which has come on the second or the third day, skin manifestation, giardiasis, things like that, we must think of it. Infections are usually subclinical, and that third set of things are not very often seen, obviously. Lymphoid malignancy, yes, but there will be other clues to it. Medications or vaccines, especially, we'll come to that again in the season of COVID and COVID vaccine. Yes, there are medicines and vaccines which are known to cause an immune thrombocytopenia. So I've already showed you this slide. So if you look at it, there's almost like a bimodal distribution of the incidence of ITP. It's more common in little boys and in the elderly age group. And actually after that, after about 14 years of age, it's always more common in women, probably because autoimmune conditions are more commonly seen in women. So coming to the pathogenesis, there's basically two main pathogens. Now, as per the definition, we all know that the megakaryocytes in the bone marrow have to be adequate, and there's a peripheral destruction. So that is a very commonly known thing. So whatever is the triggering factor leads to a T cell mediated platelet destruction. But along with the peripheral destruction by the T cells, all the autoreactive B cells, both the B and the T cells are implicated, there's also an impaired platelet production. Two reasons for this. One is because the megakaryocytes, though we say there are adequate megakaryocytes, there is some amount of antibodies working against the megakaryocytes also in the marrow. So compared to normal, there may be a slightly decreased production. The other is that the platelets, mature platelets which are in circulation, have TPO receptors and TPO stuck to that. Those are destroyed. So actually thrombopoietin levels are relatively lower in ITP compared to normal patients. So there is both peripheral destruction and an impaired production, which is why we do give thrombopoietin agonists, and they've come as a very important treatment modality for us. So if you look at this overview, if you can remember this slide, then the management of ITP is nearly almost done. I'd like to focus on the timeline. If you look at it earlier, there was only corticosteroids and splenectomies, then late IVIG, rituximab, and now TPO mimetics like eltrombopag or romiplostin are like the new kids on the block. So coming to general principles of therapy, which everybody should know from the emergency department onwards, major bleeding is rare if the platelet count is less than 20,000. So if you look at that figure by this side, so minor bleeding is the red, major bleeding is the black. So when the platelet counts drops less than 10,000 and specific less than 5,000, that's when there is severe major bleeding. Otherwise, there is only minor bleeding, and that also by the time the platelet counts reaches 20 or 30,000, the incidence of it is very rare. And beyond 30,000, almost not seen at all. So the goal in ITP is to get the platelet to a safe level, not specifically to cure ITP, which means a platelet count of more than a lakh or more than 1.5 lakh. So that needs to be kept in mind. So actually the ASH recommendation says even if you diagnose an ITP, like a patient comes to you for something else, was found to have an incidental thrombocytopenia, no major bleeding, 40, 50,000 platelets, the recommendation is not to treat until the platelet counts drops less than 30,000. Okay, so that is the ASH recommendation. We say usually around 50,000 we relax it to. So triggers for treatment, definitely the platelets less than 30,000, between 30 and 50 if there is any sort of bleeding or if there is an indication for an intervention. Very often patients get picked up when they come for other elective surgeries. In cases like that, then yes. No treatment definitely for a patient with a platelet count above 50,000. Again, having said that, there are caveats. If the patient is going for an invasive procedure, neurosurgical procedure, yes, sometimes we do treat at that point. General management for bleeding, tranexamic acid is extremely useful in the control of mucous membrane bleeding. In menorrhagia, giving combination OCPs, avoidance of platelet injections, and avoiding platelet transfusions. That's not a blank statement. When do we give platelets? There is no rule in the routine management of ITP, because even if we give platelets, it will get destroyed very fast. So we see this very often. Patients come with massive intracranial bleed. We do give massive doses of platelets like 10 PRCs, but immediately, even half an hour later, you check a recovery platelet count, it will still be sub 10,000. So massive supports are needed. And for major bleeding, which we do give in terms of intracranial bleed or an ongoing massive GI bleed, but those are temporary measures, almost like an immediate hemostatic effect, which comes and disappears within minutes to an hour. So a definitive treatment is required in a patient with severe thrombocytopenia in ITP with a major bleed. So what is the first line therapy? So as we all know, steroids are the first line therapy. Between the commonly used steroid, dexamethasone, methylpred, and prednisolone, the responses are much better with methylpred and dexa. In our institution, we tend to use dexamethasone at 0.8 mg per kg for 4 days. The response is usually seen within the second to the fourth day. May take even up to 4 days, but usually by the second or third day. And nearly 80% respond to this amount of steroids. Platelets will cross between 30 to 50,000 at least. But sustained platelet may not be seen. We will come to that. So here we usually give dexamethasone for 8 days, followed by prednisolone at a dose of 1 mg per kg. Now, how long do we give this? So different recommendations say even a short course is up to 7 days is enough, and a maximum of about 4 weeks. After about 28 days, the steroids have to be tapered. And in ITP, the taper of steroid is a rapid taper. That's within a week to 10 days, not a prolonged, slow taper like in AIHA. So that is our treatment strategy with the steroids. Other options which are expensive but highly efficacious are IVIG, 1 gram per kg. We can repeat a dose after 48 hours. Here again, most people do respond, 80 to 90%. The response is much faster than even with steroids within 1 to 3 days, but it is not sustained. So platelets that will rise, stay up for about a week to 2 weeks. So if it's required at an emergency situation like an IC bleed or an emergency surgical procedure, IVIG is an excellent option, but it's not a very good long-term option because platelets will almost nearly drop in 3 to 4 weeks' time. Anti-D is similar to IVIG, literally just goes and mops up and keeps the FC receptors of the macrophages otherwise occupied so that the platelets don't get destroyed, and the response lasts for 3 to 4 weeks. Very important, note that this can only be given in those who are Rh positive. So we need the blood grouping before that. So is dexamethasone alone first line? No, there have been studies which said dexamethasone along with rituximab yields higher sustained response than dexamethasone alone. But so if you look at that, there are 3 columns. That's platelets of target of 50,000, 100,000, and 150,000. Each of that, when you give rituximab along with dexa, the response is higher than with just plain steroid. But the relapse rates were similar in all 3 arms, 20%. So a sustained response is not achieved, but an immediate response is definitely higher with giving dexa and rituximab. We almost never give dexa and rituximab upfront in a newly diagnosed ITP. So what happens when you relapse? So how often will people relapse? I'll come to that later. or not respond, or not, maybe not relapse, but have not respond. So when you use second line agents, and what do we use? Are you two first second line agents? We have azathioprine and dapsone, and really not much scientific basis deciding which goes first. We usually start with azoran if they don't tolerate dapsone, and vice versa also. Azathioprine at 1 to 2 mg per kg. The problem with azathioprine is that there is toxicity. You can have neutropenia. Patients are instructed to check counts after 2 weeks. If there is leukopenia, then it is a purine antagonist. So counts can go down, can cause severe infections at that time. And if they are not close to hospital, cannot come for follow-up, that can be a serious problem. The other thing is that responses are slow. So responses will only start at about 6 weeks and usually only around second to third month. So to say that the azoran is not working, you need to give it with a low platelet count for nearly about 3 to 6 months. And only then can we say that it is not working. So it takes time to respond. Usually 40 to 50% once they achieve remission, we keep them on it for, if platelets cross a lakh, we keep them on the azoran for maybe a year and then start a slow taper. About 40 to 50% of those who attain remission with azoran will remain in remission. Dapsone, almost very similar to azoran, 1 to 2 mg per kg, response in about half the patients. Little earlier response, maybe within 3 weeks. But here toxicities are a little more acute. Two things. So dapsone works definitely by causing hemolysis. And the erythrocytes go and occupy the FcR receptors of the macrophages instead of the platelets. So there is hemolysis. To what degree of hemolysis is acceptable? We must monitor patients with hemoglobin and reticulocyte count. If there's severe hemolysis, a drop in hemoglobins of more than 1 to 2 grams, we will have to stop the drug. The other is a skin rash, which is very idiosyncratic, may come on, and that may preclude the use of this drug. So dapsone is a second line option. We have a paper from our institution where dapsone was given for 90 patients, both adults and children. Response was seen in about 63.3. The average time to response, again, must be kept in mind, was 3.5 months, and the duration of response was about 10 to 12 months. This is after stopping the drug also. So our overall response about 60 to 65%, and 3 patients had to discontinue. So it's an inexpensive and well tolerated and a definite option in our patients. Coming to splenectomy, major procedure, but excellent results. So there are a certain category of patients who benefit from splenectomy. Who are these? These are patients who are do not respond to first line or second line, which we have mentioned so far, who have financial constraints and cannot go for expensive treatments like rituximab or thrombopoietin agonists. Second is patients who are emergency splenectomies, like those who come in with massive intracranial bleeds or in times of pregnancy, who are close to labor. These are the times where splenectomy works. So 80% of patients respond, usually by the first or second day, almost immediately we say platelet counts, but it can take even up to a week to see the platelet counts go. The good thing is that there is a sustained response in about 70%. So after the splenectomy, those who have not responded to any treatment thus far, who had major complications, do stay in remission. 7 out of the 10 of them will be in remission even after. Having said that, splenectomy has toxicity and not just immediate. Operative morbidity is there. Usually open splenectomies are associated with infections, long stay in hospital, other complications like hemorrhage. But long-term complication of OPSI in our patients who come here from long distance, who don't have access to routine immunization of pneumococcal vaccine every 3 to 5 years, who cannot get to a hospital in time when there's high fever, OPSI is always a complication. The presence of thrombosis, which can even occur decades after splenectomy, is another thing which must be kept in mind. So we tend to avoid splenectomies in children, especially younger than 12 years of age, and in those who can afford other modalities and who don't have serious bleeding. So in those who are maybe in their third decade, who have had serious bleeding, who cannot afford other treatments, splenectomy is a good option. So again, in our setup, we do a lot of splenectomies. So the long-term outcome, about 103 splenectomies for chronic ITP between 1995 and 2009, both children and adults. Response was seen in 90% and median of 1 day. So that's an immediate rise in platelet, nearly immediate rise in platelet count. Infections were seen in 60%, and deaths related to post-splenectomy that we know of was about 1.57%, and major bleeding in less than 1%. So at a median follow-up of nearly about 5 years, about 70% still remain in remission, and this is our own data. So coming to the newer drugs, romiplostin or standard of care. So romiplostin and eltrombopag are thrombopoietin agonists. Like I told you, ITP, though the main pathophysiology is peripheral destruction, there is also a decrease in the thrombopoietin, because of which there is a mild underproduction of platelets. So adults, first it was in adults, now pediatric also, we give romiplostin and eltrombopag. Romiplostin is a subcute injection given once a week. We can start at 3 micrograms per kg and go up to about even 10 micrograms per kg, but usually between 3 and 5 mics per kg. 5 micrograms, 250 micrograms cost about 5,000 rupees. And the important thing, so in this study, their endpoint was platelet count of more than 20,000, and they gave it for 4 weeks and they saw. So if you look at just the first line, if you can look at, so treatment failure was seen in 18 out of 157, 11% of those who got romiplostin, and standard of care was basically everything else. That was seen in 23 out of 77. So significantly less treatment failure. Having said that, splenectomy also was pretty much same, 14 out of 157, 9%, and 28 out of 77. So when there are financial constraints, splenectomy is definitely an option. Most of our patients go for splenectomy rather than go for a thrombopoietin agonist. The other study is this big study called the Extend study. Again, eltrombopag is an orally available drug. 25 milligram costs about 25 milligram costs 1,000 rupees. So the doses, again, here they've given 30 milligram, 50 milligram, 75 milligram. And if you can see, the higher the doses you give, the longer the remission is, and the faster they attain remission. So in this, the long-term efficacy of this study was also come out. So apart from giving excellent results for the thrombocytopenia, must also keep in mind the toxicity. So 14% had hepatobiliary adverse effects, and thromboembolic events are more common in those who have thrombopoietin agonists, and that must be kept in mind. Coming to rituximab, another favorite of ours. Slide is moving on. Yeah. So rituximab. So rituximab, as we all know, is an anti-CD20 monoclonal antibody. So 2 doses have been tried. The standard 375 milligram per meter square. Now that is actually the dose from non-Hodgkin's lymphoma trials, or a lower dose, which is 100 milligram per meter square per week, or no, just 100 milligram, just blanket 100 milligram weekly for 4 weeks. And they can be used, like I said earlier, upfront with dexamethasone or in relapse cases. So when they use this rituximab, they found responses between 50 to 70. Important to know that the median duration of response, so you give it weekly for 4 weeks, patients stay in remission for a maximum of about 10 months or maximum year. Beyond that, most of them do relapse. So again, it's an excellent short-term option, but not a very permanent option. So what happens when you fail second line of therapy? Then you go to more immunosuppressive drugs, typically like chemotherapy. So cyclophosphamide is a drug, but cyclophosphamide causes neutropenia, must be kept in mind. Vincristine, again, anecdotal reports, we do use it in our center very rarely when we don't have other options. But again, toxicity is high, neutropenia is high, so patients must be kept close and monitored. MMF is another drug. It's an orally available drug, almost very similar to how azathioprine acts. Azathioprine is a purine antagonist. This is a more selective purine antagonist because it's a inositol monophosphate inhibitor. So the important thing is a patient who's had toxicity to azoran with cytopenia may very well develop cytopenia with MMF also, so needs to be kept in mind when you're giving a trial of MMF. MMF 1,000 milligrams, we start at 500 milligrams and go up in an adult to even 1,000 milligrams twice to thrice a day. Time to response is much shorter than with azoran or dapsone, within 2 to 4 weeks. And once they attain response, again, as long as they're on drug, very often for a while there is response, but they lose response even earlier than with drugs like rituximab. Danazol, you'll find hardly any data on this. Danazol is more a drug that is given for a bone marrow failure syndrome or a lower risk myelodysplastic syndrome where there's pancytopenia. But in some of our patients, as a last-ditch attempt, we do give it, and there is sustained remission in nearly half of them, 46 of them. Again, toxicity is very important to keep an eye on. There is acne, increased facial hair. There is amenorrhea. So again, women in reproductive ages need to be counseled about the decrease in reproductive potential, the fact that they may not get their cycles on time. All of that needs to be explained to them when we start danazol. So coming to patients with ITP in India, first the role of a bone marrow. So in our patients who are very often referred from outside, who come with having usually first or second line therapy already done, if we don't have a bone marrow done, nearly always we do a bone marrow. And that is what I would advise if you're working in a setup where it's not just a small niche of patients who live around you who come, if it's not in a private clinic where you have patients who are going to be regularly on follow-up. If you're a referral center, if you're a mission hospital where patients are going to come only when they're sick, it is very important to establish a diagnosis foolproof so that when they don't respond, you're not stuck and you just know you have to go on to second line therapy. So a bone marrow, yes, in our setting. First line drugs, oral corticosteroids, Dexa pulse, followed by steroids 1 to 4 weeks, and then taper over 4 weeks. IVIG, if money is not an issue, definitely it's an option, less toxicity than giving steroids. In children, also an option. So very often 60 to 70% of adults and children will respond. In children, much more response, relapse rates are lower. In adult, it's the opposite. Expect a relapse or a non-response to treatment or not optimal response to treatment within 20 to 30%. So what do you do then? Second line, like we've gone through, dapsone, azathioprine. Splenectomy rarely these days is an immediate second line unless there is a major bleeding episode or another indication for a rapid increase in platelet count that is required. L-Trombopag, rituximab, favorite of private practitioners across the country. Most patients are started on it. There is some response to it, but they can't afford it, and so they come to us. So these are good treatments for short term if finances are not a problem, but long term, they are difficult to sustain. Now, on a second line therapy, 50 to 60% will respond. Again, to keep in mind that response takes time. So you must explain to the patient, we start on you, but it may take 3 to 6 months for your platelets to come up. Only beyond 4 to 6 months of one of the first two drugs do we say it's not working and go to another drug. Third line, danazol, L-Trombopag, pulse cyclophosphamide, rituximab, others like MMF and CSA. So all these are really depending on the patient situation, really difficult to advocate one versus the other. Okay, so coming to certain special situations, in pregnancy, what we would do, Dexa pulse definitely, but having said that, to keep a close eye on the blood pressure and the sugars, because as opposed to a normal patient, this can have serious consequences on the outcomes of pregnancy and the baby. So they should be done in management with the obstetrics team. IVIG is very safe if they can afford it. Azathioprine from the renal transplant patients, we do have good experience that patients who conceive on Azoran can have children without any, almost never have any major abnormalities. And so we do say if you are stable on azathioprine, you concede on it to continue it, and it's very safe. Dapsone, not often we give, but it can be given. In the presence of a CNS bleed, if money is not an issue, IVIG immediately, even if money is to try and get it and give it. Anti-D also works, Dexa pulse immediately. In very rare cases where there's a massive bleed, where the patient needs a decompressive craniectomy, at the same time, a splenectomy is one of those heroic things we do, which are very, very fruitful. And 2-3 days down the line, everything looks so good and you're glad you pushed and did that. So those are situations that you must keep in mind. If somebody does not want any long-term drugs, wants an immediate now and wants to be well for a year or so, rituximab is an option. Weekly injections for 4 weeks can almost guarantee them that for about a year they'll be okay, and beyond that they may relapse. If patients don't want surgery, if we don't want to advise surgery in a young person, then thrombopoietin agonist or rituximab. If you're looking at durable responses, then a splenectomy is definitely one of those. TPO agonists, we can come down to about a low level, keep it on, and then watch and see. But basically, data is from Western population where they've given it for nearly a year or so. Many of our patients cannot afford that. So that's the end of ITP. If there are any questions that you'd like me to take now.
I think thanks Sharon for the talk on ITP. There was one question in the chat box. It said to kindly comment on if there's any evidence between oral and IV Dexa pulse for ITP in terms of immediate and long-term response.
Yeah, so actually no difference. Dexamethasone is excellently absorbed. So if a patient comes to us casualty who's a known ITP, who because of lockdown stopped her medicines and came with 3,000 platelets and menorrhagia, actually we just give tab Dexa 40 milligram, tell them to take it for 4 days and come back to our outpatient. On the other hand, if the patient has got other things, fever, not eating, vomiting, or has a GI bleed, IC bleed, then we give it IV. So actually oral Dexa is what we give almost all the time in priority 3 patients and casualty or in the outpatient setting. If it's an inpatient and other requirements for IV drugs, only then do we give IV Dexa.
Any further questions? We can continue to type down the chat box of any questions to the next topic, which should be taken on TTP. There's one more question. How long to wait for platelet response after DEXA pulse?
So we almost never stop with just a DEXA pulse in a newly diagnosed ITP. So we always give the DEXA pulse followed by the oral prednisolone 1 mg per kg, and on that 1 mg per kg we wait for a full 1 month. So very often there will be some response. I'm almost never seen a no response. Platelets may go up to 20, 30 at least, which is safe enough for us. At the end of that, at the end of about 4 weeks of the steroid, then we taper. At that point in time, if your platelet count is less than 50,000, then we start a second line agent. And then we go through the whole thing, second line agent for about 3 months, depending on which they respond to, and then take it from there.
If someone had an acute bleed and then we treated with the pulse and then they continue on steroids and then they been stable for some time and recur again in terms of having a bleed, will you go back to the first line?
So if it's a massive bleed at any time, we do give a DEXA pulse. So there are some patients who come in while very early in their treatment. Usually if it's in that newly diagnosed ITP in that first 1 month and they've come in with a bleeding event, we don't discharge them till there's some sort of hemostasis is achieved. We keep them, make sure the platelet counts, and like I said, very often platelets just have to cross about 15, 20, and then we just supportive management, use of OCPs, hydration if it's a hematuria, GI bleed, look for an ulcer. There may be an underlying ulcer, things like that. So if you look at that and treat that along with just pushing your platelet count a little bit above 20, that stops. But if a person relapses by again the second or the third month, yes, we do give a DEXA pulse at that time acutely to push it up. So then we're coming to things like steroid dependence. A lot of our patients will do very well when you start tapering the steroid, they'll drop. So in that, the two schools of thought. In textbook, it says never give long-term steroids. Having said that, some ITPs, we do keep them on 5-10 milligrams prednisolone. Another good option, less toxicity, is to give them monthly pulses, maybe not even 40. Patients themselves will tell you, when I take this, my place comes. So maybe just 20 milligrams of DEXA monthly along with a second line agent for about 2 to 3 months. And then after that, they seem to be okay.
How often, what will the disease modality, treatment modalities in terms of patients who underwent splenectomy?
So refractory ITP is a very sad thing. So we sort of counsel them for that. We tell them there's a 70 to 80% chance, but actually we are hoping like crazy that this is it. So post splenectomy, refractory thrombocytopenia is a major issue. Again, you go back to one of the previous drugs. So very often these patients would have responded transiently to one of the previous drugs, azathioprine or dapsone, would have lost response, or you wouldn't have tried other vague drugs like MMF or cyclosporin or danazol. You go back to one of those, or again, if they come with a massive bleed, you treat them with IVIG or rituximab. Those are rare, but yes, we do have them on follow-up. At that point in time, very, very important to also revisit the diagnosis. We have missed things like Bernard-Solier syndrome, post-splenectomy that we have picked up. So if it's a child especially, and there's never been a response to steroid, that's one thing. So like I told you, most ITPs will have some response to steroid. If there's a person who's never responded to steroid, refractory post-splenectomy, go back and visit the diagnosis, see if platelet function tests are required, if there's something we've missed.
One more question in the chat box. How frequently should we follow up on a chronic ITP?
So that depends on how stable your chronic ITP is. So if your ITP is on azathioprine, 4th month platelets hitting above 1 lakh, I'll say come back after 3 months. And if there's no problem with cytopenia, I'll say come back after 3 months. For 1 year to 2 years, if you have maintained remission that's above 1 lakh, then we start taper. So patients who reach that point in time, we say once in 3 months. But a person who's sitting with platelet count less than 20, 30, I would call back a month. Or we'd say anytime there's a major bleeding, come back in. So we also patients who we're sending on very low platelets, we do give them DEXA tablets and say, if you develop a very bad bleed, take the tablet at home itself. We give them tranexamic acid and say, apply the paste and also come in, because a lot of our patients come from very...
How fast do we taper?
Taper it fast. In a newly diagnosed ITP, 1 week to 10 days, we taper and stop.
I think that's about for the questions for ITP. Please feel free to type in further. We'll go on to...
Okay, so coming to TTP, TTP much more esoteric, much more actually exciting, dramatic disease than ITP. So TTP stands for thrombotic thrombocytopenic purpura. Actually, it's a part of a syndrome, the syndromes of thrombotic microangiopathy. Very interesting because it's diverse. There are many clinical and pathological features which fit into many systems. So diagnosis, which we'll come to, can be delayed. There are 9 primary TMA syndromes I'll come to, and there can be many precipitating causal features. And the last, which is of importance to us, I won't be touching on this class, is transplant-associated TMA. So these are the main 9 syndromes. You just have to know it for a classification sort of way: hereditary and acquired. In the hereditary, we're talking about the Upshur-Kallman, which is a homozygous deficiency of ADAMTS, or a compound heterozygous, 2 different mutations also. Complement-mediated TMAs, which mostly go to the nephrologist. Metabolism-mediated TMA, cobalamin deficiencies and complex abnormalities. Coagulation-mediated TMAs. Acquired is what we will talk about mainly, TTP. Shiga toxin-mediated, which is a more pediatric diagnosis. Drug-induced immune reaction, drug-mediated, which is toxic dose-related, and again, complement-mediated TMAs. So these are the 2 broad classifications. I'll be talking mostly about the ADAMTS13 deficiency or the acquired TTP. So acquired TTP was first described by Moskowitz in 1924, where a 16-year-old girl succumbed to illness and where he saw a picture of petechiae, purpura, bleeding, and a microangiopathic hemolytic anemia picture on the peripheral smear. This patient succumbed to the illness. Now, why is it a challenging diagnosis? Because the presentation is diverse. There's multi-system organ involvement. It's very acute. Patients present very sick. And very importantly, there's no one diagnostic test. So a lot of it depends on putting together a constellation of symptoms, signs, and some lab findings which are typical, but again, don't say this is it. And the lab diagnosis is very often delayed. Results of ADAMTS don't come in on time. And even after antibody testing is rarely available. So which is why it is a challenging disorder. So basic pathology, what is ADAMTS? ADAMTS stands for disintegrin and metalloproteinase thrombospondin type 13. So it's basically a protein simply called von Willebrand cleaving protein. So somewhere you'll see things like VWCF, which is CF is cleaving protein. So ADAMTS's old name is also that. It cleaves von Willebrand factor multimers, which are secreted from vascular endothelial cells. Okay, so ADAMTS deficiency, because there is no ADAMTS or decreased levels of ADAMTS less than 10%, large von Willebrand factor multimers are present, and these literally catch the platelets, keep it, and cause thrombi in small vessels. So it's a sort of a consumptive coagulopathy. So your platelets drop, at the same time microthrombi are formed, and so there are thrombosis. Okay, so I've already told you the Upshur-Kallman syndrome is caused by a homozygous or a compound heterozygous deficiency. Acquired TTP is an autoimmune disorder caused by autoantibodies to ADAMTS, because of which there's ADAMTS deficiency or functional deficiency. So coming to symptoms and signs, very important, MAHA, must keep it in mind, macroangiopathic hemolytic anemia. Basically a picture where red cells are broken down, there are presence of schistocytes, there is hemolytic anemia, because of which there is a good marrow response, so there's reticulocytosis with thrombocytopenia. So signs of them will be pallor, weakness, fatigue. Because it's a hemolytic anemia, there will be indirect hyperuremia and jaundice. So MAHA, thrombocytopenia. Like I said, because there is small clots are formed, just think of all the possible small vessels that can be obstructed. Bowel ischemia, so patients may come with abdominal pain, GI bleed, vomiting, nausea, very non-specific. Cardiac ischemia, elderly people can come with chest pain, acute coronary syndrome types, hypertension, heart failure. CNS presentations are commonly seen. So seizure, almost anything, almost like an SLE with CNS involved, anything can be seen in a TTP CNS. So you can have coma, encephalopathy, stroke, seizures, focal abnormalities. And renal ischemia, again, we'll come a little bit more about the renal involvement. And fever. Fever, very high fever should suspect an underlying cause or a precipitating cause. Laboratory findings, platelet count of less than 30,000, so a severe thrombocytopenia, hemolytic anemia, and LDH, which is elevated, a haptoglobin, which is decreased, which we don't do here, increased reticulocyte count because your marrow is working, and there's, unless there is a secondary or underlying lymphoma or an infiltrative disorder like a malignancy in the marrow, usually the marrow response is good and there is a brisk reticulocytosis. Indirect hyperbilirubinemia, peripheral blood smear, which will show schistocytes, NRBCs, reticulocytes. Creatinine may be elevated, but having said that, very high creatinine, more than 2.5, should definitely make you question the diagnosis of a TTP and look for an alternative diagnosis. So a mildly deranged renal function is almost always seen up to about 1.5, 1.7. There may be proteinuria, there may be hematuria, but very often they will be putting out good urine and the renal failure will not be profound. Usually normal coagulation, which is again taught to us again and again in ICU, normal coagulation, low platelets, keep in mind TTP. So diagnosis, microangiopathic hemolytic anemia and thrombocytopenia without a clinically apparent etiological diagnosis. So how often do these patients present with what? So we all know and we like having diagnosis put in neat little boxes. We all know the pentad of TTP, starting from our top CNS involvement, renal involvement, fever, thrombocytopenia, MAHA, AHA, you have the diagnosis. Normal coags, if it's also there, fantastic. But that's almost very rarely seen. So most of the TTP data comes from a huge Oklahoma database. A lot of the studies are from that. So if you look at that, in that particular database of 70 consecutive patients who had severe ADAMTS deficiency, that is almost like proven TTP, only 3, that is 4%, had a complete pentad at presentation. So very often, maybe in hindsight, they may develop all these 5, but initially it may be just 1 or 2 of 3 of those features. So thrombocytopenia and MAHA is always there. That has to be there, without which you cannot or you'll have to seriously consider another diagnosis. Neurologic involvement come up to a third to about a fourth. Renal involvement, mild renal insufficiency is there in most patients, like I said, but a severe renal insufficiency, we have to look for other things. Fever is commonly also seen. So complete pentad may not be there most of the times. So what do you look for in underlying? Must look for a severe systemic infection. Very often it's ICU patients who are already there who have other infections going on. Systemic cancer, solid organ malignancies can present with TTP, especially late stages adenocarcinomas or malignancies of undetermined etiology who also have a bone marrow involvement. You may also have a leukoerythroblastic blood picture where you'll have a high count with the left shift. Those are cases where you must suspect TTP also. Again, like I told you, this TTP, TMA, HELP, all of them are sort of like a spectrum. And some have more endothelial damage because of which there is increased von Willebrand factor. In a pure TTP, it's because of the ADAMTS deficiency. But the clinical features may actually a lot of them may overlap because in effect, what happens is that there is a platelet-rich fibrin clot which is formed in small vessels. So severe preeclampsia, eclampsia, HELP syndrome are all commonly seen. Severe acute hypertension can also precipitate autoimmune disorders like SLE commonly seen, and solid organ and HCT post that TMAs are common very often because of the drugs that we use like calcineurin inhibitors, and these have an extremely poor prognosis. So this table just tells us that presence of, so we very often do not have ADAMTS levels at the time of diagnosis, almost never. And ADAMTS levels, usually we suspect we send it, may take up to 2 to 3 weeks or sometimes in 6 weeks for us to get the result. So a severe ADAMTS 13 deficiency of less than 10% is characteristic of TTP. And almost like if you get that, after you finish treatment, you can look back and say, yes, this was a TTP that we had treated successfully, whatever. But it is neither sufficiently sensitive nor specific to decide initial therapy. And that is what we must keep in mind. So it's a clinical diagnosis and we go by the pretest high probability of having TTP, and I'll come to a slide on how exactly we approach it. Okay, so we look at this in patients who were subsequently found to have proven TTP, how many of them, or we look back and say, yes, this was and it wasn't anything else. In the different underlying categories, how many of them did have an ADAMTS which was severe? In a transplant setting, only 1 out of 12, in pregnancy, 3 out of 17. In an idiopathic, where we don't have anything else, or in a primary TTP, which may be most of the patients come to a medicine department because those with underlying disorders would have gone to the respective specialties, things like that. In a person who's coming with idiopathic TTP, fortunately, nearly 50% of them do have severe ADAMTS 13 deficiencies, which are detected. But in other causes, you may not always find a low ADAMTS 13 also. So this is something new in the maybe pathophysiology of ADAMTS 13, which may also explain why sometimes ADAMTS 13 levels may be normal, but still they have TTP, or they may be less than 10%, but patient may be behaving well. So if you look at it, this is the ADAMTS, where's my slide? Yeah. So that is the ADAMTS, that one, and it's usually in what we call a closed form. So physiologically, it's in a closed form. If you look closely onto your screens, you can see this is something called the cub domain, the green, and this is the spacer domain. So in normal conditions, when there's high shear in small vessels, the cup domain goes and gets bound to this, which is the CK domain on the von Willebrand. Now, the bottom line here is the von Willebrand factor, the von Willebrand molecule, huge molecules there. And once the cup domain goes and gets caught onto this, it sort of causes an opening of your ADAMTS13. So there's a split between the spacer and the cup, and that goes on. The spacer domain is what goes on to causing the cleaving of the von Willebrand from its large multimers into small multimers. Okay, so normally it's shut. When it goes through these big, these high flow, high velocity vessels, it goes and gets caught, it opens up. The spacer domain is allowed to come out, be open to come and bind onto the A3 part of the von Willebrand and causes cleavage. Now, what they have found out is that very often the antibodies, there are antibodies towards almost most of these domains of the ADAMTS, but very often there is a very select antibody which is against the spacer domain, which may not be detected or may be difficult to detect. Okay, so what is the significance of this? So these antibodies are not only present in acute situation, but even after treatment, the ADAMTS13 level may rise. So you've given immunosuppression, because of it, those normal anti-ADAMTS13 IgG antibodies are down, ADAMTS level increases, but these select anti-spacer antibodies may still be going on and binding to the spacer domain and preventing the cleavage of the von Willebrand. So von Willebrand may still be in large multimers sitting there and causing ongoing hemolysis, though if you look at antibody levels and ADAMTS13, your ADAMTS13 level may be seeming to rise. Okay, so it can be used as a follow-up. Again, this is almost theoretical now because we don't even do anti-ADAMTS13 antibodies here. The big IgG test that we don't do it here. Specifically, definitely we do not do the anti-spacer antibody, but these may be some of the reasons why, even if you had antibody testing and it seems like your antibody levels are coming down and your ADAMTS13 level is going up, still clinically the patient may be deteriorating because there are specific antibodies to some regions. Okay, so coming to treatment. So the treatment of hereditary TTP is where there's absence of ADAMTS is to give ADAMTS by plasma infusion. Those who develop, when plasma is again derived from people, it has proteins. So very often they develop life-threatening reactions after being exposed many times, in which case recombinant factor from plasma, from factor VIII, you can have recombinant ADAMTS has been marketed, very expensive, not available. Most of our patients with the congenital TTP do keep getting plasma or cryosupinatin infusions. They do develop severe allergic reactions. We pre-medicate, give it slowly, give it over 2 days. Those are the strategies that we employ. Very important to remember that before plasma exchange, the survival in TTP was only 10%. And with plasma exchange, the survival has come up to about 70 to 80%. So this is one of those disease-changing treatments, plasma exchange, that has come. So coming specific to plasma exchange, now if you're looking for treatment of TTP, there is an excellent article. It's a BJH guidelines for TTP, 2012 version only, but the basis of it is the same. The ISTH has come up with an updated version in 2019. That's the more, it's got the recent drugs in. But for the basic evaluation treatment, I would encourage you all to go back and look up that BJH paper. This is the one I've referred below here, 2012 paper. So PLEX should be started as soon as you suspect a TTP. So 1.5 plasma exchanges, you can calculate how much volume is required for a plasma exchange. Any nephrologist or dialysis therapist will be able to make that calculation. You can also do it. All medical calculators have that. So what the BJH recommends is what they call solvent-derived plasma, which is basically a highly purified FFP. So we don't do solvent detergent FFP. Instead of that, we either give just plain FFP or we give cryosupinatin, which is basically cryoprecipitate from which the von Willebrand factor is being removed. So we say it's poor in von Willebrand multimers. So we usually supplement plasma exchange with FFP plain or with cryosupinatin. In CMC, it's almost always cryosupinatin because it's available. But if cryosupinatin is not available, FFP itself is enough. So once the platelet starts increasing, you can decrease the volume of exchanges. Same time, if the platelet count is worsening, there are new symptoms, you can exchange, you can increase the number of plexes to even twice a day. How long should you continue plasma exchange? A minimum of 2 days after your platelet count causes 150,000. Okay, so we usually use cryosupinatin, which is cryopro plasma, relatively deficient in von Willebrand factors multimers, but FFP itself can be used. Along with that, upfront to start steroids. So high doses of steroids, usually either 1 mg per kg of methylpred, or even up to, there are studies given even in severe case up to even 10 milligram per kg, like a pulse methylpred 500 milligrams. We usually start at 1 milligram per kg per day. We sometimes do go up to 1 mg twice per kg per day, twice daily, if there's no response by the second or the third day. But generally 1 mg per kg of methylpred. So there are no RCTs which says Plex alone versus Plex plus steroids. So we do start both almost immediately. The role of rituximab upfront. So we'll come to more trials on this. So because TTP is such a life-threatening disease, patients come with so many illnesses, you want the antibody levels to go down as soon as possible. You want the thrombocytopenia to improve, and you want to start treatments like anticoagulation to prevent severe ischemic events. So because there is such a need for acute improvement, people have wanted to know whether adding more agents upfront will help. So here they've used rituximab upfront along with steroids and Plex most oftenly. There is definitely a much more rapid response when they use rituximab, but again, it's not sustained. In our setting, and if you look at ISTH guidelines, which I'll come to next, they do not recommend the use of rituximab upfront in a patient who's a newly diagnosed first-time TTP who's responding. Now, we'll come to what we mean by responding. But if a patient is not doing well by third, fourth, fifth day of Plex, there is new ischemic events coming up, platelets are not rising, or if at any time it's a relapsed TTP, then rituximab should be offered upfront. So in relapsed TTP, now standard of care is both Plex, steroids, and rituximab. And rituximab at doses, again, the NHL dose of 375 milligram per meter square weekly, or even lower doses have been tried, and I'll come to a trial with a lower dose. So if you look at this, was more recent, probably in 2019. It's actually a letter to an editor. So it's low dose rituximab and plasma exchange this is for newly diagnosed TTP. So you look at the first one, the median time to response is actually 5 days. So within 5 days, platelet counts cross 50,000. But if you look at it, about 12% do relapse within day 30. So again, if you see this is the drop of platelets, if you can call it. So when you give rituximab, there is response, but 12% within that 1 month itself may again have a relapse. And overall, if you see, overall about response about 70% in a year's time, and nearly 70% remain in remission, but 30% will have a relapse of TTP, even if you give rituximab upfront. If you look at this, again, if you look at your screens closely, this is the platelet count growing up, looks good. This is the CD19. So we use CD19 as a surrogate marker for B cell lysis because we are giving anti-B cell monoclonal antibody rituximab. So at presentation, your CD19 levels are high, and then it gradually, precipitously drops and then goes up. At 12 months, you again have it. But if you look at, and all this looks very good. So ADAMTS13 again is negligible. There's no ADAMTS13 activity. Within 1 month, it goes up. And then subsequently, it does remains about 10% at least, which is what we need. If you look at the last, this column very carefully, these are patients, these same cohort of patients, they got rituximab 100 milligram weekly for 4 weeks. And these are days. So green is the platelet count. They all did well, but by around like the end of 1 year, there was a drop in a lot of the patients. So nearly 30% of them not lost, 30%. There was a drop, at which time they again needed a rituximab boost. At this point in time, this particular study, they used 375 milligram per meter square, after which again the platelets went up. Okay, and again by around 800 days it drops. So rituximab is a good option. There is rapid recovery of platelet count. It's very useful in an emergency situation, but may not be sustained. In a relapse setting, definitely in patients who are not responding, who have organ involvement, who come in very late, then yes, upfront rituximab, even 100 milligram per meter square, may not even require 375 milligram per meter square. In our setting, we never give rituximab upfront in patients. So a lot of our patients actually just suspected outside. They've received Plex at least 3-4 times and steroids, and then they come here. Even then, we just continue steroids and plasma exchange if it's the first time. But if by the end of 7 days there is no response, rituximab is an option for us. Or if there's got new events like new CNS events like stroke. Now, very important, no platelet transfusion. These patients are all severely thrombocytopenic. So do you give platelets or not? If you give platelets, if platelets have been given by mistake, is it a major problem? Does it directly contribute to thrombus formation? No, not really. So they've thought, yeah, so what they found is that most patients do get some platelets before they are diagnosed to have TTP, and it does not amount to any severe abnormality. So there was no mortality because they gave the platelets. Having said that, platelets are not appropriate. So we only give it if there's a major bleed. Very important note that actually we don't need platelets to put in the plasma exchange port. The BJ's guidelines say it. Having said that, in our department, we almost always give 2 PRCs for our peace of mind and the nephrologist peace of mind to put the plasma exchange port in. But actually, recommendations say you don't need to do that if it's done under ultrasound guidance by an experienced person. Long-term outcomes. So those with severe RMTS13 deficient, that's we're looking at those with less than 10% of RMTS13. So their risk of relapse is 43%, and it can be a late relapse, even beyond 1 or 2 years. Relapses are more common in those with secondary TTP, which goes parallel. So patients who have underlying APLA, patients who have underlying SLE do tend to have relapses as opposed to just an idiopathic TTP. So if you have a suspected TTP, so if you suspect a TTP, immediately look at a peripheral blood smear, see whether there's thrombocytopenia, MAHA, look for any obvious identifiable cause, HIV, drugs, malignancy, which are obvious, then yes. So if there's a leukoblastic blood PG, if there's hepatosplenomegaly, if there are nodes, then yes, bone marrow is part of the initial examination. Node biopsy is. If the patient is newly diagnosed HIV, then ART is part of the initial treatment. But if no obvious cause or if there's a frank SLE going on, then yes. But otherwise, then do all the connective tissue workup. But otherwise, again, just initiate treatment. So before starting, what else do you do? Other workup, blood film, reticulocytes. Look for organ involvement, basically TROP-Ts, ECGs. If there's abdominal pain, amylase lipase. If there is chances of pregnancy, then pregnancy in a reproductive age group woman. Blood grouping, RMTS13 level should be sent to your lab and asked for them to process as fast as possible. It's very often batch test, may not be available widely, but it should be taken and sent off before the initiation of our plasma exchange. So products to be arranged are FFP, BAR, cryo, supernatant. Start plasma exchange usually with 1.5 plasma volumes, and then you can either increase it or decrease it depending on the platelet count. If HIV positive, like I said earlier, start ART immediately. This recommendation says if there's severe illness to start rituximab. In a relapsed case, yes, start rituximab. Or if there is severe disease, yes, sometimes we do. Or if the patient has been treated. Very important, this is one part which is not very often discussed. When the platelet count crosses 50,000, we must start aspirin and LMWH, depending on the creat, of course, or heparin, because remember that there is ongoing thrombosis. So very, very important, because you may think that, oh, platelets are coming up, the patient will wake up the next day with a stroke. So once the platelet crosses that, even when there's plasma exchange ongoing, we need to give aspirin and LMWH, should not forget this. So what do we mean by refractory TTP? So if the platelet count crosses 1.5 lakhs in 2 consecutive days with no evidence of hemolysis or decreasing hemolytic parameters, then it's response. So refractory TTP is when there's failure of platelet response after 4 to 7 days of correct plasma exchange. That's 1.5 to 2 volumes plasma volume changes, or a clinical deterioration in a patient. So platelet will come up, there is new bowel ischemia, there's a new acute coronary event. Very often it's a stroke. Then that is called refractory TTP, and incidence are about 10 to 42%. Where do we see this? In patients with very low RMTS13 and high inhibitor titers. So what do? You can go up on the steroid dose. You can go up to 10 mg per kg. You can add a pulse. You can increase the plasma exchange, add rituximab. Other options are, so rituximab I've already covered, either 375 milligram or 100 milligram per kg. So when do we recommend rituximab? When there's no platelet response 4 to 7 days on plex, or there's a clinical deterioration. We usually give 375 milligram per meter square only. We have not yet changed to the 100. Now remember that 60% of your rituximab is removed in plasma exchange. So rituximab should be timed to be given after the plasma exchange, 24 hours. I mean, there should be a gap of at least 24 hours, and it should be repeated weekly for at least 4 doses. When all fails, again, splenectomy, but splenectomy is a very high-risk procedure in these patients who are already desperately sick. We almost never do splenectomies in these cases. We give other drugs because there is T cell and B cell mediated RMTS13 deficiency here. So cyclosporin is a major T cell inhibitor. So cyclosporin can be used. Cyclophosphamide vincristine we recently used for a patient who was not doing well, who could not afford rituximab, worked extremely well. Counts did go down. Keep an eye out for infections. Give growth factors as required to prevent severe neutropenia. But wonderfully, the platelets came up, and she also had a neurological event which she recovered from. Bortezomib is another drug, proteasome inhibitor, has found its role. It's almost like the masala in Indian cooking. It's there in almost any disease now, be it GVHD, myeloma, refractory ALLs, everything bortezomib is used. Again, bortezomib can be used here also. Other anecdotal drugs, N-acetylcysteine directly works by reducing the von Willebrand fat multimers, can be used in desperate situations. Recombinant RMTS13 found its role in congenital TTP where patients have severe reactions to FFP, very expensive, not available. Now the new kid on the block really here is the anti-von Willebrand factor therapy. Okay, so it's called caplacizumab. So it's an anti-von Willebrand factor immunoglobulin. What it does is it actually just prevents the binding of von Willebrand to platelets. It does not tackle the antibodies that RMTS is against. It directly tackles the platelets getting caught to the von Willebrand. So we all know that the platelets bind to von Willebrand via the A1 domain. So this is an antibody against that A1 domain. So here, if you look at it, the long von Willebrand multimers are connected to the platelets, that part. Here, what caplizumab does is it goes and blocks those binding sites. That's the orange stuff here. So because the caplizumab goes and binds to the A1 domain of the von Willebrand factor, the platelets are allowed to go about their usual business. There is no sequestration, there's no thrombocytopenia, there's no thrombin clot which is formed. So what is the advantage of this? This is the landmark study in 2016. Again, by 2019, there are real world data on it, which shows that caplizumab really does work. In fact, it's part of the guidelines now, the ISTH guidelines. So we looked at the dotted lines. It's where they use the blue line is where they use caplizumab. Orange line is where only Plex was used, or not Plex, placebo. That was anything else. The dotted lines is where placebo and caplizumab is used. So basically, what happens is caplizumab causes a much faster improvement in the platelet count, and even faster if you use it with plasma exchange. Okay, as evidenced by the blue dotted lines. So time to response is much significantly less compared to placebo alone. So these are the latest guidelines, the ISTH guidelines. So you look at this, not a very good slide. I'm sorry, you can look at it closely. The very important thing is there a high probability of TTP clinically? It's as simple as, is there a thrombocytopenia with the MAHA with a mild renal dysfunction and no other obvious etiology for this? If that is so, then to start plasma exchange and steroids, consider starting rituximab if there is severe organ involvement. If there is facilities of getting a rapid RMTS13 level, and if RMTS13 level is proven to be less than 10, then there is a role for upfront caplizumab as per recommendation. And I think the NIH in Britain has authorized use, so they do use it upfront. We have not used it till date here. This is a slide which talks about the challenges in TTP with older patients, but I think in India it's just a challenge with any TTP. So basically there's a delayed diagnosis because RMTS13 is not easily available. So it's not like you can confirm your diagnosis. It's very often a clinical diagnosis. So atypical presentations in patients who have underlying other disease or even just idiopathic TTP. So clinical presentation needs to be kept in mind. High morbidity and mortality because they come in so sick with multi-organ dysfunction. So very often may end up in medicine because no specialty wants to take it. So in those cases, we need rapid treatment to be initiated and long-term follow-up to recognize who are the patients who are going to relapse and to prevent relapse. So these are the challenges in treatment of TTP. So that's actually the end of TTP. TTP is a spectrum. So TTP is the classic, almost the easy diagnosis of that. The other spectrum of this is the vascular microthrombotic disease, where there's fulminant liver failure, other causes, TTP-like syndromes they are caused, where plasma exchange works like we do now in fulminant liver failures. Heparin-induced thrombocytopenia, thrombocytosis is also a sort of immune thrombocytopenia with the TTP component where you have thrombocytopenia and thrombosis. COVID-associated TMA is coming in now. Not so much of an endothelitis, but there are 1 or 2 papers which say there is endothelitis, and because of which there is von Willebrand factors being implicated. VIPIT and WIT are the latest terms. So VIPIT is vaccine-induced procoagulant thrombocytopenia thrombosis, which is especially seen with the AstraZeneca vaccine, which has been changed to actually vaccine-induced thrombocytopenia thrombosis. So these are all almost similar concepts where there is thrombocytopenia and thrombosis. Here it's platelet anti-factor, anti-PF4 antibodies like in HIT. Treatment very often is immunoglobulins, plasma exchange, and similar things. So these are all almost like a spectrum and just things to be kept in mind when you are approaching a patient with TTP. So that's my last slide. Any questions? I think I've overshot my time. I'm very sorry.
That's fine. I think that is a very detailed, but then still very relevant topic and very clearly elaborated on the approach to TTP and ITP. I think it shed quite a bit of light to what, from the knowledge of what PGs might be having it right now, and something that we see on a daily basis, like how we mentioned, having patients coming in with a clinical diagnosis to be made early in the course of the disease. Any questions? We'll be uploading soon this lecture in our Department of Medicine YouTube website. If any questions or queries, please also mail to med@cmcl.ac.in. If no further questions, we can wind up for today. Is it like athleticism is going to come soon into our setting?
So actually, I did my first presentation on TTP when I was a registrar in 2016-17. And then I was reading up for this. I didn't realize that IST and the NIH is approved. So yeah, it's probably going to come in. Yeah.
Thanks, Sharon. I think this is a very relevant topic that's been covered by you in a very simplified way. Thanks a lot. And
thank you.
We can, she's very approachable. If any doubts, please feel free to her in person also.
Absolutely.
Thank you. We'll wind up for today.
Yeah, thank you.